So you mentioned rescheduling, and I think that's something that we're all sort of watching and hopeful for, that we'll see some movement there. But so say it does get rescheduled. I think what Schedule 3 is what's on the table here. How would things change for you if that were to happen?
Well, it's going to change a lot of things. So Schedule 3 is like ketamine. I think codeine number 3 is in Schedule 3 also. So first of all, it's still going to be federally illegal. But locally, I could do a prospective study looking at cannabis in the treatment of, I'm going to give you an example. I do have a protocol, which I wrote for this, for chronic migraine. Migraines defined by more than 15 headaches a month. And I can look at a placebo or a 20-to-1, 1-to-1 ratio, 5, 10, 15, 20 milligrams. So it's a prospective study. There'll be several arms. I could do that. You can ask me who's going to fund that. I'm going to say right now, nobody. Who's going to fund it? We're going to fund it. I have a benevolent family, DENT family. DENT was a philanthropist back in the 60s, who, by the way, had Parkinson's disease, started the Institute in 1963. And there is a family, non-for-profit family foundation that supports research within the Institute. And they, by the way, for the last 6-7 years, have unequivocally supported my research in cannabis. And that has given me the opportunity to publish, to put us on the map. And they still support, but we're not talking about millions, we're talking about significant amount, but they do support us. So yeah, I'm going to get some seed money from them to support a study, if I can do that, if it becomes a Schedule 3 drug. And then I can publish that article prospectively, randomized study, part of the money from seed money from the DENT Family Foundation, part of the money through the DENT Cannabis Clinic. We'll readjust money to put it in research. So instead of putting it in our pockets, we'll put it in research, self-funded, if you want to use the term. And then we can publish that. Once we publish that, I could show it to the insurance companies. I can show it to the medical societies, and then let them critique it. And one of the things is, one of the problems I think you may understand is cannabis, medical marijuana or medical cannabis programs are too expensive for patients.
Yeah.
Now I did a way you don't have to pay me cash. That's a positive for the patient, right? But they have to pay in cash. And some of these patients are paying $800 a month. They can't afford it. And let me be honest with you, in the medical marijuana program, most of the people can't afford it. And because they can't afford it, and the insurance companies throw their arms up and say, we're sympathetic. We know that if you put somebody on medical marijuana, they'll take less opioids, they'll take less Xanax, they'll take less sleeping pills, they'll take less anti-inflammatories. So it's good for the insurance companies, but they fall back on the fact, no research.
Yeah. So
if I have a prospective study, the first thing I'm going to do is present it to every CEO of every insurance company, because let's pay for this, because I save you money. I keep patients out of emergency rooms. They have less testing because their quality of life have improved, and they're using less drug. So that's the first thing I'll do. So that may change something at that level. Then the medical societies will look at it, critique it. It'll be published in peer-reviewed journals, which is very important. And maybe we start moving at the medical society level. So I'm optimistic that for me, it's going to be fine. It's going to be a step in the right direction. I'm not sure if it's going to help the business of cannabis because it's still federally legal. There's still taxation issues, banking issues, as you all know. And I don't get involved in that. I just read what I read. So, but in my perspective, I think it's a positive move.
Yeah. So will insurance companies, well, I mean, there's a lot that goes into it, but it being a Schedule 3 drug would not, preclude them from covering it?
It could be a Schedule 3 drug, but anything you use it for, it's off-label, because it's off-label because it's not been approved in that disease. For example, what disease? Say migraine. That makes it easy.
Yep.
There's 36 million migraineurs in this country, 36, or 700,000 patients in the United States with MS.
Yeah.
That's a lot of patients. Will they approve it? They won't, because show me the research.
Right.
How can I prove a drug off label that there's no science that shows it works? Then you go testimonials. Well, I have patients who can't live without it. That doesn't count. It doesn't. Testimonials don't count. Randomized phase 2, phase 3 studies do count.
Yeah.
So that's what we'll have to do, and we'll do it.